I want to just start off by thanking the AO for having me be part of this course and present a case tonight. So educational pearls that I want to make sure we cover and you're thinking about as we go through this case. I want you to think about strategic sequencing. I want you to make sure you're thinking ahead when you're doing some of these more complex cases. You want to make sure you don't compromise your future fixation, especially when you have more complex injuries. And then those injuries that are more unstable typically require more fixation. So keep that in mind. So our patient we're going to go through is a 55-year-old male. He was involved in a 4-story fall out of a window. He presented and had a rather isolated orthopedic injuries initially. He had some rib fractures, had a right pretty bad bicondylotibial plateau fracture, then also presented with this AP pelvis. He was hemodynamically stable on arrival. He was awake but altered. He was a little bit confused on presentation. He was initially admitted to the ICU, but he was cleared for surgery the following day, again with isolated orthopedic injuries. And you can see on this AP pelvis that he has an obvious right acetabular fracture. You can see a large, what appears to be an anterior column component that exits quite high posteriorly. You can see disruption of the ilioischial and iliopectineal lines. And you can also see some cranial displacement of his right hemipelvis if you look closely. And he's also got a fracture of his inferior ramus. And these are the iliac oblique and obturator oblique views. You can again see in the bottom left-hand corner his anterior column component that exits high and posterior. You see the fractures of inferior ramus, some comminution associated with the anterior column and the inferior ramus. Can't really appreciate any posterior wall involvement on this image. You can also see basically directly down the fracture plane of the sacral fracture on the right side. And then on the iliac oblique, you can again see the displacement of the anterior column. It's a little bit difficult to appreciate the posterior column fracture as it's obscured by the Foley balloon as well as some residual contrast in the bladder, but you can also just see the displacement of the hip. Here are inlet and outlet views that further characterize the pelvic ring component of the injury. If you look closely, you can see the vertical displacement of the right hemipelvis. In addition to the acetabular fracture, you can see the cranial aspect of the sacrum here on the right side compared to that on the left side. You can also look at the caudal facet on the right side compared to that on the left side. And you can see some posterior translation of the right hemipelvis as well in the inlet when you compare it to the contralateral side. So the patient was initially put in traction given the cranial displacement of his right hemipelvis, which helped his reduction of both his acetabulum and his sacral fracture. So then we obtained a CT scan to further characterize his injury. So as we go through it, you can see the exit point of the high and posterior anterior column fracture. You can see his zone 2 sacral fracture on the right with some rather significant comminution as we go down. And as we travel more caudal, you follow the anterior column fracture line down to the dome of the acetabulum. And then you can also see a small non-displaced or minimally displaced posterior wall component as well. And then you can appreciate the associated comminution anteriorly, and then also the inferior ramus fracture. So we go to the 3D reconstruction images. This just gives you a better idea of the morphology, the fracture pattern. See the anterior column component. You can see the posterior wall that's minimally displaced. You can see the orientation of the posterior column fracture that exits fairly caudally just on the cranial aspect of the ischial spine. You can see the displacement of the sacral fracture with the associated comminution. You can also appreciate the transverse process fractures of the lumbar spine, signifying rather significant disruption and a very, very high energy injury. And these are just the inlet, outlet, and AP views of the 3D reconstructions of this injury. I'm just showing what we've already gone over, the cranial displacement of the right hemipelvis, associated transverse process fractures on the right, and also the associated both column acetabular fracture on the right side. So I thought this might be a good time to open the floor up for discussion, get other faculty's thoughts on this type of injury. Specific questions I had thought about when looking at this case were, one, how to sequence this, and what approach and/or approaches to use in order to treat this combination of injuries. Is the sacrum something you do open or do a closed reduction? Is the posterior wall something that might need to be addressed? And then how much fixation do we actually need for something like this for both the acetabulum and the sacrum? So if anybody has any thoughts.
Yeah, why don't we start with Mike Stover? Mike, what do you think? Comminuted sacral fracture and then this associated both column ipsilateral.
The concern is just how well you can reduce the sacrum, because that's going to set everything in place as you move forward with your anterior column and then finally your posterior column. But unlike other fracture types, you're not going to have the ability to just clamp your sacrum and then maybe play with your acetabular fracture for a little bit and adjust it if needed. So I would probably start prone, go posterior, and reduce the sacrum. With zone 2 sacral fractures with bone quality and high energy like this, I commonly will use also spinal pelvic fixation, which may not be a bad idea because you're going to really start to bring the anterior column back to the intact ilium, which will take some force, and it may have some challenges with your iliosacral screw fixation alone. And then assess whether or not you can reduce the posterior column, posterior wall through the ilioinguinal, as with your second stage being the ilioinguinal. And then if you can't, then you might have to even go back to a Coker-Langenbeck.
So if you anticipate a significant difficulty with assessing and obtaining an accurate reduction of the sacrum in something like this, do you think there's enough slop, if you will, through the comminuted rami fractures that you could make up for a slight malreduction of the sacrum, but still be able to get the associated both column?
Well, that's what you're hoping for, but the problem is really going to be with the posterior column when it comes down to it. And, you know, that's going to not really, the rami aren't really going to come into play if you set your sacrum, go ilioinguinal, put your anterior column in place, and then you're going to have a challenge if you're off with the posterior column component, especially with that wall trying to key it in. And I think that's where your challenge will be.
Keith, do you think this is an associated both column that you could reduce in isolation of the sacral fracture?
Well, that's what I'm hoping.
It's a relatively straightforward articular injury, or it seems to be.
Yeah, I mean, the traction film, excuse me, looks promising. But I'd certainly start anterior, I think, and try to reduce the anterior column back to the intact innominate bone. And then if things were going well, and I thought I had a really good reduction of the posterior column, which I think is unlikely in this setting, but possible, and I'd continue. And then this would be the rare exception because of the factors that Mike's already talked about, where I'd do the sacrum last. Otherwise, I'd do the anterior column first, hopefully, and then go prone so I'd have simultaneous access to the posterior column and sacrum at the same time.
How many times in your career have you kind of put together a floating acetabulum with a unstable posterior ring injury?
I mean, successfully?
I guess that would be where I'm going, but
Yeah. Well, hope springs eternal. I haven't done it yet. I've had to bail, but at least conceptually it makes sense. I think starting with the anterior column is a reasonable first step.
So just for the participants to clarify, because we've told them that you rarely get into trouble by starting with the reduction of the posterior pelvic ring, and in fact the preference would be to start with the reduction of the posterior pelvic ring. Why in this case are we saying not to?
I think it just has to do with the fact that because of the zone 2 comminution, um, you might be close, but you might be still have a significant malreduction. And if then the intact innominate bone is malpositioned relative to the anterior and posterior columns, then you have an obligatory default to, if you're lucky, surgical secondary congruence, which is probably where you're going anyway. This sacral fracture, I think, is beyond my ability to get anatomic.
I think your other option could be just to use iliosacral screws initially to approximate a reduction, give you some stability. And then if you're having trouble with the posterior column, you could start supine with it. But if you had trouble with the posterior column, then you could do it in 2 stages: anterior with iliosacral screw fixation of the sacrum, put your anterior column back together. If you have trouble with the posterior column or you don't like your reduction, then you could go prone for your second approach. You could take your screws out. You could adjust the sacral fracture at the same time as you adjust the posterior column through the simultaneous posterior approach to the pelvis and the Coker-Langenbeck.
All right, Kevin, why don't you take us forward?
I mean, I think all those are great comments, and all those are things that I thought about with this case, and I've thought about this case for a long time actually, and ended up coming up with a plan to start supine, start with the ilioinguinal and attempt to fix the acetabulum first, and then assess the sacrum radiographically, both with fluoro, and we have access to intraoperative CT. The radiographic modality of choice is really not all that critical as long as you have access to some form of that. But I was planning to use that to essentially assess the reduction of the sacrum and how close it was, and then possible close versus with percutaneous fixation versus a prone ORF of the sacrum after I fixed the acetabulum was my plan going in. So went in, did an ilioinguinal approach, fixed the anterior column first, basically did a reduction of the anterior column to the what would otherwise be the intact ilium posteriorly, and then held it in place with some provisional K-wires, as you see here on the left. I find it very hard or very difficult to put a clamp when the anterior column exits this posteriorly because the abdomen is in the way, and so basically just held the reduction with a fair buff clamp, and then placed this 3/5 screw through the crest, and then placed this plate with screws down into the posterior ilium for the reduction, basically to counteract that external rotation deformity of the anterior column. And then after that was placed, clamp the anterior and posterior columns together, and then place posterior column screw fixation. And then once the posterior column was fixed, then I fixed the acetabulum to the anterior pelvis using this intrapelvic plate with screws anchored back into the intact ilium, and then screws anchored into the perisymphyseal bone on both sides of the symphysis for additional fixation. And there was a, and I noted this preoperatively, there was a cortical reduction read on the superior ramus here, on the caudal aspect of the anterior column, that I felt like I could get pretty close. And as far as putting the acetabulum back in space. And so I used that in order to get that reduction.
So Kevin?
Yeah.
So up to this point, you'd reduce the anterior column to what would be the intact ilium. You reduce the posterior column, but now you're fixing across your ramus fracture with your sacrum still displaced.
Correct. Yeah.
Any thought about just stopping with your articular reduction and then moving on to the pelvic ring, the posterior pelvic ring?
Yeah, for sure. And I considered that. What I was a little bit concerned about was I was trying to get the rotation back, and I felt like reattaching the acetabulum to a more anatomic position anteriorly would correct any rotation that I had in the right hemipelvis with the acetabulum fixed. And I felt like if I did that, then I could potentially pull traction through the hip and pull the sacrum back down to a more anatomic position, and the rotation would be closer than it would otherwise be if the anterior ring wasn't fixed. And these plates are fairly malleable, and so I felt like I had enough play through the plate that I could adjust it as needed. That was my initial thought anyway.
Okay.
And so after I fixed the front of the ring, I then assessed the back, and as you can see, The right hemipelvis is still cranially displaced quite significantly. And I put him in, I think it was about 20 to 25 pounds of distal femoral traction, and I actually pulled the sacrum down quite nicely. And I just did these red lines here just so you can see it a little bit better because it's hard to appreciate on these fluoro films. We got an inlet view. The inlet view looked I thought pretty good. It looked like things were lining up pretty well. And then I actually did an intraoperative spin at this point, and I don't have the images in here just because the images on our intraoperative CT scan just save the axials, which in the OR I manipulate the images to get direct axials, coronals, and sagittals. And so those are the images that are actually more useful, but it doesn't typically save those. And so I actually adjusted it once and then spun the patient again. And I thought the reduction actually looked pretty good on the intraoperative CT scan. So then I elected to place a transiliac transsacral screw at the S2 level. And I guess at this point, the sacrum's distracted a little bit. I'm curious to get people's opinions on compression at this point. And I'm obviously put in a transiliac or a partially threaded transiliac transsacral screw here. And I did end up compressing through this fracture, but I'm curious as to what other people's thoughts are on something like that.
Yeah, why don't we hear from John and then from Mike Stover on compressing sacral fractures with a closed reduction.
Yeah, I think you have to get some sort of compression. Otherwise, you're going to be locking in a fixed gap. And I think you can use, preoperatively, you can do a lot of templating in terms of your anticipated screw length. You have an intact side to build back to. If you measure back to the midline, you get a sense of, what double that would be to kind of get your real screw length. And so when you measure that intraoperatively, you can get a sense of, hey, this is going to be, 10 millimeters longer. So I'm going to compress and add 10 or take off 10, whatever your sequence is going to be, but it'll give you a good kind of indirect way to build to what your length should be. But I do think you do have to get some compression. And I think if you get the reduction, which looks pretty good with what Kevin's shown, I think that's going to be a safe compression.
Mike Stover, is compression always safe in common in sacral fractures?
I don't know if it's always safe. I don't think I'd be able to say that, but I do think it's necessary. So a lot of us have argued that's one of the reasons to do open reduction of sacral fractures, because you can usually get an area of a read of a reduction despite a lot of fragmentation, and you can follow the compression along that region as you tighten the screw down. I haven't went as fancy as measuring the other side to the midline to take a guess at my screw length. I think that's a great idea. I typically just use a very expensive clamp, which is the first screw that goes in that ends up too long, and then I change it out.
All right, Kevin.
And so then I placed he didn't have a corridor for a transiliac transsacral screw at the S1 level, so I placed an iliosacral screw. And I guess the question is now is whether or not this is enough fixation for that sacral fracture. One transiliac transsacral screw, then one iliosacral screw that goes a little, that's where the fracture line is basically in the middle of the screw. I didn't personally think this was enough fixation given the amount of displacement. That's kind of one of the things I wanted to emphasize in this talk. I think leaving, historically, if you basically relying on one transiliac transsacral screw for this amount of displacement with this injury, I think this would probably have a high chance of ultimate failure.
Do you think on that view, on that fluoro view, are you as happy with the position of the right sacral ala and its cranial position? Maybe that's just one.
Yeah, I mean, I think it's hard to tell. On that one view, I do agree. It looks like it might be a little bit cranial, but so yeah, I think on that view, I think it's a little bit high.
Yeah, but your inlet view came together nicely. All righty.
So the other thing I think worth bringing up is there anything to do about this now? It's a kind of a small, somewhat peripheral posterior wall fragment, but it's more displaced now than it was preoperatively. And then with the reduction of the sacrum, is this now something to try to reduce? I tried to reduce it from the front and was rather unsuccessful. I think it's sometimes difficult to, especially with a piece this small that doesn't have some cortical bone extending up the lateral ilium to accurately place a screw in a piece this small. Curious what other people's thoughts are.
What do you think, Keith? This is a pretty unusual posterior wall fracture in terms of its size and morphology to have with an associated bolt column, isn't it?
Yeah, it's always a little disturbing when it's displacement secondarily is worse than primary. To sort of makes you think that maybe you're not quite as accurate as you thought. But you could barely see it on the first axial. So I think before I did anything, I would get a new CT. I don't think I would base that on an intraoperative spin, but I'm not a big believer in that, even though we have it. But I'd get a new CT. If the area of involvement is small, I'd have to look at how much intact adjacent roof there is, as well as the inferior exit. Then you have to make a judgment call. This isn't the typical kind of wall fracture you'd subject to an EUA. So I would defer until I had another study.
And going back to what I mentioned earlier about not kind of boxing yourself out for future fixation, I did not think that this was enough fixation for the sacral fracture, and basically intraoperatively felt that I was probably going to need to have one of my spine colleagues back this up with lumbopelvic fixation. So I think it's important to get this view, this operator outlet view, to make sure you do have a pathway for an iliac bolt, despite all of your hardware that you placed, because those bolts are rather large, and if you have screws that go down the central aspect of this pathway, then it makes it very hard to place an iliac bolt on the right side of the hemipelvis. So I think it's important to get this view. Likewise, if you're going to do the acetabulum anteriorly and then flip prone for the sacrum, you have to get a lateral of the sacrum to make sure that you are not blocking the pathway for your transiliac transsacral screw at the S2 level with one of your screws that goes through your plate that's into the intact ilium. So those two things are ways not to hose yourself. So these are the postoperative x-rays, postoperative AP, I should say. And I did get a postoperative CT scan. As you can see, the sacrum's not perfect, but it's pretty close, and we confirmed safe hardware placement of both the iliosacral screw at S1 and then also the transiliac transsacral screw at S2. And then we go further caudal down to the acetabulum. And you can see that posterior wall that's residually displaced with a little bit of gap there peripherally. And the anterior and posterior column components seem to be closed down nicely and sealed well, other than displacement of that residual posterior wall.
So what criteria on this CT did you use to decide whether or not that posterior wall needed intervention or not?
Yeah, I mean, I think that's a good question. I elected not to go after the posterior wall and elected to leave it. I felt that it was small peripheral, and again, it's a little bit atypical for a both column. Usually these are more avulsion type injuries and don't lead necessarily to hip instability. So I felt like it was small enough that from my perspective, it didn't necessarily need fixation. Would anybody else have gone back and done another approach and fixed it?
Anybody want to chime in on that one?
Probably. I
We see
would.
the AP as a post-op AP.
I think the challenge now is fitting it in. So just looking at the CT, I'm a little concerned about maybe just a little external rotation of the ilium, but you know, whether or not it's going to fit in, I've done it before, and I can tell you that it's really not very satisfying when you go back there and it doesn't fit in perfectly.
Mm-hmm.
Okay.
And these are just selected cuts of the sacrum. showing the ultimate reduction of the sacrum. This is just a 3D and kind of giving a little bit of a better appreciation despite all the scatter where the sacrum's kind of sitting in space. So I think it's probably just a little bit residually cranially displaced, as Mark was referring to. These are just selected cuts of the acetabulum.
And Mark and Kevin, if I could just ask a question about the posterior wall, would anybody think there's any benefit to doing an EUA like we would for a more standard posterior wall? Even though I get it, this isn't a standard associated with an associated both column. It's more of a tension failure usually, but is there any role for an examination under anesthesia to do any sort of dynamic instability?
I think that's a good question. I didn't think there was in this case for the very reason you mentioned, just because these typically are tension failures. I didn't really feel like he had a dysplastic hip, and he had good coverage of his dome. So I elected not to do that here, but I think that's a very reasonable question. I'm curious as to whether anybody else would have done that.
On the AP, it looks like he's not retroverted as far as his native anatomy or secondarily. The thing that is bothersome is the posterior superior location. So I think everybody's had those cases that are associated with a dislocation in the same location, which look relatively innocuous, but were then treated by somebody non-operatively and led to recurrent instability, and then you've got problems. So even though it's a long ways through normal anatomy to get there, how old is he?
He's 40.
He's a young guy. So I agree with Mike. I probably would have gone after it. But again,
sorry, he's a little older than. Sorry, I misspoke. He's in his 50s.
But what's the downside of going after it?
Yeah.
Good
I think
question.
that, you know, the downside's the second surgical approach and the potential complications associated with that. And also, Mike, as you said, although this the reduction in the anterior and posterior columns to each other looks quite nice on all the imaging that we've seen, but you know, we've all seen the situation where the reason the posterior wall looks more displaced is because the reduction of the anterior to the posterior column is extruding the posterior wall because the reduction's not accurate. I don't think that's the case here, but it's really distressing to do a secondary cochlear and realize the reason you can't put the wall back in is because you got to start over.
Yeah, I've been there.
So this guy ended up going back to the operating room. Really, it was between 2 and 3 weeks post-operatively. He actually developed a significant ileus and had a bowel perforation post-operatively on post-operative day, like 5 or 6. And he was basically NPO and on TPN and significantly nutritionally deplete for a while after that, and actually dehisced part of all of his wounds that were slow to heal. But then they went in and my spine partner went in and did percutaneous lumbopelvic fixation on the right side for further stability. And here he is about a year out. He's got a little bit of arthritis in his hip, but his hip doesn't really bother him. It's actually his plateau that's really driving his outcome on his right leg because his plateau was pretty bad. But if you look closely at these images, it looks like he has broke his iliac bolt from its attachment on the rod. And so my spine partner is planning to take out his hardware sometime in the near future.
Is his sacrum united?
I think it is. I think it is united. I haven't repeated his CT scan, but he's not really having any pain around his hip or pelvis. He's got some weakness, but otherwise I'm not really having any discomfort.
Oh, that's a great case.
And then just review the educational points. I think it's just important to have a sequence strategy. We talked about multiple strategies of this case. I think multiple different types of strategies would have likely been successful. You got to make sure you have adequate fixation. Last thing you want is for the sacrum to fail, given how unstable it was and how displaced it was initially. You want to make sure you have a contingency plan. And then as far as what I would do differently, I think looking back at this case, I might have done something with the posterior wall for one. if it would have probably been a little bit more difficult for me to accept a closed reduction intraoperatively and without an intraoperative CT scan. I do think that from my perspective is helpful in assuring that things are close, because sometimes they can be a little bit difficult to appreciate on x-ray. And I wish I would have coordinated his spine fixation a little bit earlier, just because we waited a few days and kind of got behind the 8 ball with him getting pretty sick and being in the ICU for a while. So his spine fixation was a little bit delayed, which caused a little bit of stress as far as whether or not his sacrum was going to displace. But ultimately, I think he's had a pretty reasonable outcome for his pelvic ring and his acetabulum.